Welcome to 2 Minute Anaesthesia in Critical Care. Today let's discuss blast injuries. Blast injuries are defined as any injury caused by the effect on a living organism by a blast wave generated by an explosive device. Blast injuries remain relatively uncommon. In the US, between 1987 and 1997, a 10-year period, there was approximately 500 deaths, secondary to the use of explosions from bombs or incendiary devices. Whilst in China, looking at safety data for workers over a 17-year period, there were 16,000 deaths. So what are the sources of explosion? They can be chemical, nuclear or physical. Chemical, i.e. TNT, from nuclear reactions, and finally physical reactions. This is secondary to the build-up of pressure within inside a container, i.e. a gas bottle. This leads to a release of a large amount of energy and the formation of a blast wave, which can be greater than 10,000 to 100,000 times the initial volume. This is composed of two main parts: the high pressure wave followed by a blast wind, which leads to the displacement of air. Heat produced during the explosion can then spread through the winds. This will have two main effects on tissue as it hits the patient. Stress waves. This can lead to fragmentation at the surface of high density tissue, leading to microvascular damage. Whilst conversely, due to the difference in density, this can lead to acceleration and deacceleration of tissues at different rates, leading to tearing of organs and tissues. The clinical effects are based into four different sections: primary, secondary, tertiary, quaternary. Primary, this is due to the blast wave, the high atmospheric pressure. The greater the atmospheric pressure, the more likely to relate to injuries. And this commonly affects air-filled spaces, the ear and lung. Secondary, this is due to the movement of projectiles through the air, leading to wounds and blunt trauma. And tertiary, this is movement of the body through the air, secondary to the blast wave. And finally, quaternary, all the other injuries not directly related to the blast wave, i.e. burns. As you can see from the previous slide, the injuries relate to the mechanism of action. The two most common sites is the ear and the lung. Air-filled spaces and structures with an air fluid interface like the lung, GI tract, the tympanic membrane, blood vessels carry the highest risk. As the air is easily compressible versus water, the organs which contain this air are those more susceptible. Clinical features. Let's discuss this in a system-based approach. ENT, tympanic membrane rupture, ossicle fracture and dislocation. Note, the absence of tympanic membrane rupture is considered a negative indicator of potential lung injury. Lung injury is broad and composed of contusions, alveolar rupture leading to pneumothorax, air embolus and an ARDS-like picture. Cardiovascular, this can lead to hemorrhage, hematoma between the epicardium and the endocardium, tearing of coronary vessels leading to arrhythmias and myocardial infarctions. CNS, there's a risk of brain injury, GI, perforation, hemorrhage and mesenteric tears. Orthopedic fractures, maxillofacial, facial injuries, dental injuries and ocular can lead to retinal injury. The trauma-related scores do not specifically relate to blast injury, but they can still be used. Here are two examples. The AIS, or the abbreviated injury scale, is an anatomical catalogue of injuries based on severity 1 to 6, divided by the specific body regions. Conversely, the injury severity score, the ISS, requires the highest AIS score of the three most injured ISS specific body regions and sums them to give a number between 1 and 75. The management is broad and is based on an ATLS-based approach with an MDT approach. It is largely supported with an awareness for complications including air embolus, traumatic rhabdomyolysis and compartment syndrome. Once again, thank you for watching.